All right, it's exactly 5 past. I think we should start. So welcome everybody. My name is Nopiwe Job. I'm based in Cape Town, South Africa, and we are Digital Medics. So welcome to this virtual session where we'll be talking about the creating, sharing, and evaluating of digital health education to improve global health equity. Let's go to the next slide. I'll be introducing some of our team members in a second, just after letting you know what we'll be talking about. So number one, we'll be talking about why digital health education. And then next, we'll take two case studies that our team have conducted. The first one will be talking about an advocacy training course designed for community health workers. The next case study will be a vaccine education rollout that we did on social media. And then we'll have our discussion, which we are most excited about. But yeah, let me introduce you to our team members. Let's go to the next slide, Kat. So I'm Nopiwe. I will be the moderator for today. I'm a research analyst. I am based in Cape Town, South Africa. I told you, and I work very closely with Jamie Johnston, who's our evaluation director. In this presentation, you're going to hear from Sime Johnston, who's our learning experience director, together with Victoria Ward, our medical director, and they'll be telling us about the first case study about the advocacy course. Next, our managing director, which you see there in the middle, is Ati Paul. You'll hear from her during the discussion. And also among us, we do have the founder, Charles, which I'm sure you will hear from as well during the discussion. Let's go to the next slide, Kat. So we are Digital Medic. We are an initiative from the Stanford Center for Health Education. And literature has shown that there are many millions of preventable deaths among mothers and children that could have been prevented through the care of a trained and well-supported community health worker. This to us highlights really the importance of making high-need health information accessible and available to frontline healthcare workers, like, for example, community health workers. So we really are committed to reaching healthcare workers and the communities that they serve worldwide with evidence-based information in a timely manner, in a relevant manner, contextual, and most importantly, the information must be understandable. Hence our mission, which reads, to create engaging, high-need digital health education that can scale quickly and cost-effectively to health workers and communities worldwide. Let's go to the next slide. So that is who we are, and we are a team of clinicians, global health researchers, and education experts. So we help identify high health need topics, and we use a human-centered design principles to create credible, relevant, actionable, enjoyable learning experiences for both health workers and maybe the communities that they serve. So we do this by collaborating with a wide variety of groups to train frontline healthcare providers to educate communities we deem vulnerable. And we also try to understand the impact of our health education interventions through some research. When we go to the next slide, we estimate that the work we do reaches about 27 million learners across 140 countries with our 44 global collaborators. So when we look at the map, we are showing you in red where our offices are based. At the tip of Africa, that's where I am, that's Cape Town, South Africa. And in the north of America is in California, Palo Alto, where our offices are at. Now, friends, without further ado, I want to hand over to Sime, our Learning Experience Director, to tell you more about how we do what we do. Thank you, Sime.
Thanks, Nopiwe. So now I'm going to share a little bit about our content. So broadly speaking, our digital health education materials are open access, free and adaptable. They're evidence-based, engaging, visual, and downloadable. That said, every project has unique requirements and audiences. So I'm going to share a little bit about our process for content development. highlighting some of the aspects that are particularly important for promoting health equity. So this really starts with bringing together multiple perspectives. We have on our team learning designers, production specialists, project manager. We have medical illustrators and animators, as well as medical experts. So we bring together this production team and the medical experts, both here at Stanford and partnering institutions. We work with government officials at relevant ministries of health. We also work closely with implementing organizations to make sure that things are useful and implemented well. And last but not least, we work with learners. So whenever possible, we work with representatives of the target learners to develop content together. And what this looks like may vary depending on availability and various logistical considerations. But this can involve surveys, focus groups, design advice, content reviews, and co-creating assets together. I'm going to go into each of these next points on the next slides. So the next thing would be human-centered design. So we take an iterative process, or we use an iterative process to really understand who our learners are and make sure that they're at the center of our whole design process. This is kind of a simplified view of what it looks like, but I just wanted to highlight that at each stage of the process, we have feedback loops where we're sharing content and the designs with learners and the stakeholders who can inform us about the relevance and whether they're meeting the needs that we set out. So you'll see that those feedback loops can take on different formats depending on what works best for the specific context. Sometimes this is interviews, other times surveys or focus groups, sometimes content review. But it should be that early on, if we're, as we're gathering input and including people early on, those feedback loops will start out big where we're learning more about what we need to create, who we're creating for, what those barriers are, and what's already existing out there. And those feedback loops start to kind of get smaller and smaller so that our production can become more efficient. So we're getting early and often, or getting feedback early and often. And I'm not going to go through every bullet point on this slide, but this is kind of the general production pipeline that we try to use, and we can refer back to if we want to during the discussion. So I also wanted to mention that process is really designed to understand the primary audience, but we also want to keep in mind that a lot of content can be useful to other audiences as well. So we try to identify early on if something is going to be scaled to a second audience. And this really has an impact on our production process and kind of how we design the content that we're making. It affects the script writings that we can write in a way that is good for translation. So simple, clear language, avoiding colloquialisms and idioms. It also informs how we design our visual assets. So deciding how much localized detail to include, and also the ease of updating the production or the files with new audio. So sometimes this is a balance, and we have to try to make decisions and get feedback from the learners throughout this this design phase to try to strike that balance of meeting the needs of the immediate learners, but also knowing that we want to create a global good and something that can be used more broadly. It also just affects kind of our behind the scenes production setup and how we're preparing ourselves for efficient adaptation. I'll show you just one example of how we've approached that, kind of striking that balance of having localized detail with assets that are designed for scale. So this is a video that incorporates very simple characters with local voiceover, and we also included some food photography. So for some things that have more detail and that are a little bit more culturally specific, we wanted to use assets that could be swapped out easily in later versions of it. So I'll just show you just a few seconds of this video.
But when he was 6 months old, Mama said it was time for come with us. I still remember his first meal, sitting upright on Mama's lap. She gave him mashed butternut mixed with some breast milk to make it smooth. He spit his food all over Gogo, and that made me laugh a lot. Baby brothers make a big mess. When he got better at eating, Tawa started eating the same foods we eat. Mama says that at 6 months, babies need to begin eating a variety of solid foods, like eggs, porridge, and all different colors of fruits and vegetables.
So I'll pause it there, but this video has been translated, I think, into 6 languages and pretty quickly.
But when he was 6 months old...
Sorry about that. So the last aspect that I'm going to talk about is just the fact that we try to deliver content across devices and data barriers. So we understand that not everyone has access to internet or high-speed data, and depending on who we're trying to reach and the content that we're creating, we can use different formats. So we've worked with SMS and IVR, which is interactive voice response, and created content that we load into a custom app. So this is a digital medic app that is on iOS and Android, and viewers can see content on their phones offline. So if they don't have access, they can download a course and when they're on Wi-Fi and then have it available to them later on. We also promote our content through online platforms like various social media platforms, and also have created some web optimized learning experiences using platforms like Coursera, edX, and progressive web apps. So to show you what this all looks like in practice, we're going to tell you about a couple of case studies. The first case study we'll look at is this advocacy training for community health workers. This was a digital course that we created in collaboration with the Community Health Impact Coalition. And just to give you kind of an overview of what the course looked like. So this was a course designed for community health workers living and working in low and middle income countries. It had 4 modules, all with the aim of helping CHWs learn to advocate for themselves and for their communities. So it started with giving them a history of the background of CHW programs, then talked about the advocacy process, then went into how you can use storytelling to advocate for change, and also gave some information about technology tools and how to participate in this global conversation. We created the course in 3 languages, so English, Spanish, and French, and it totaled about 5 hours of learner content, so about an hour of video, and also had reflective exercises, some readings, and other videos from external sources and assessments. I'm going to show just a few clips to show you what the course or what the video content looked like and some of the different styles that we included in it. So in the first one, you'll see we have a puppet narrator whose name is Sarah. I'll tell you a little bit more about her on our next slide, but she introduces the course and kind of guides you through the process.
As CHWs, we have a valuable perspective and unique understanding of the communities where we work. Advocacy and storytelling are tools we can use to make others aware of an issue and to call on them to take action. This training aims to equip you with the skills to have your voice heard on the global stage. We hope you take these messages to heart, become passionate advocates for your work, and join forces with fellow CHWs to raise the voices of CHWs around the world.
So you also saw some photographs and simple illustrations that we use to demonstrate and kind of support the concepts that she's teaching. We also use some metaphor throughout the course for more complex topics. And this example, this ladder of participation, is one that seemed to really help ground the information and also provided a way for people to I guess talk about their experiences and describe kind of where they were, where they felt like they were on the ladder of participation. So I'm just going to show you a few seconds of that. Nope, maybe not.
CHWs and global advocacy. How can CHWs participate in global advocacy? To answer that question, let's take a look at the ladder of participation. The ladder of participation shows different levels of participation in the advocacy process, from no participation to full participation. The lowest level is manipulation. At this level, CHWs have no voice or power. Other groups manipulate and lie about CHWs. For example, a group might say that CHWs want a new health policy, even when CHWs are against the policy. The next level is decoration. CHWs are treated like decorations at events. CHWs might be invited to a fundraising event.
Okay, pause there. And then the third example is showing how we co-created some content with CHWs, or in this case, a former CHW. So we incorporated real stories and tried to use those as examples for the content that we were teaching.
While not all stories put our very lives at risk, some stories can put our livelihoods and reputations at risk when we're shining a light on problems in the system. Let's hear from a former CHW, George Minwa, on how he's encountered this in his own career.
Hi, everyone. My name is George Munya, and I'm from Ghana, West Africa. I was a community health worker in Ghana for several years. That was from 2007 till about 2012 when I left Ghana. As a community health worker, my main job was to provide all forms of services to very remote villages. And today I'll share an experience from one of my work. So in Ghana, and this may be true for some other parts of Africa, we have a day called National Immunization Day. And this is when usually as a community.
Okay. I'm going to pause there. I know the story, you might be eager to hear it, but I see Kat put some more information on the course in the chat. So next I want to talk about how we created this course and especially the human-centered design process that we used. So throughout the entire production and even beforehand, we worked with a group of 25 CHWs from all around the world. So they were informing us about a lot of things like the context and the need for advocacy and how to talk about that So they help to inform, the information that was included in the course and whether or not it was worded in a way that that would resonate well with learners and be understandable and clear. They also gave feedback on the character design of the narrator. This included things as small as, having her smile more, or what she looked like, her clothing and attire, and thinking about how she might be approachable and resonate well with viewers from all over the world. They also named her Sarah. So we feel very, very fondly about Sarah and how she was developed with this group. They also gave feedback on our mobile app experience, user experience, and some other things like including more gender representation in the course. And all of this feedback was given through 4 2-hour sessions on Zoom, as well as in ongoing WhatsApp group conversation. We launched the course initially on our Digital Medic app. This is both on iOS and Android and is available offline for viewers. We have 384 enrollments there. And we also, so Chic, our partnering organization, posted it on a progressive web app as well. And that has been reaching even more learners, so 3,000 enrollments. We continue to get feedback from the people who are taking the course and learn that it was also very useful to have the course in an in-person format. So a lot of the CHW advisors were telling us that this would be really good content, but some people don't have access or are not going to take it on the digital format. So in response, we developed this facilitator guide for a hybrid learning experience where they can use downloadable assets from the course, the videos, and have somebody who has learned the material guide others through the entire course. This was developed as a facilitator guide as well as a learner guide. And right now this has been used to train 320 CHWs, but it has also gotten approval in Uganda to be used in the official trainings and is going to be used to train about 5,000 CHWs, they're called BHTs there, in upcoming months. So we're very excited about that. I'm going to hand it off to Jamie to talk about our second case study.
Hi, everyone. It's great to be here today. So I get the honor of presenting our second case study, which really exemplifies a lot of the things that Sime was talking about in terms of how we think about creating content, disseminating it, and understanding its effectiveness. And so this project actually came out of collaboration with one of our fellow Chic Coalition members, the Wuku Koak Maya Health Alliance, which is an NGO that operates in Guatemala and specifically serves rural, more underrepresented populations and communities throughout Guatemala. And we did this work in collaboration with researcher colleagues at UCSF and Upswell. So I'll move to the next slide. All right, so what came out of the needs that were discussed in Guatemala and with Wuku Koak was that there is a lot of missing information, particularly in indigenous languages and the Mayan languages, that really kind of omit getting basic health information to these communities. And this need was particularly highlighted throughout the COVID-19 pandemic with regard to vaccine education. And so our teams came together and decided that we wanted to do something about this, and that social media may have been an optimal way of reaching large groups of communities through social media assets, a video series. And so we decided to conduct a needs finding to understand what the needs were, and if we could take some of the content that our team at Digital Medic already created around vaccine education and try to contextualize what we had to better reach these communities. And so we embarked upon this project in several phases. And the first phase was really this human-centered design that Sime discussed, where we were taking this iterative feedback, these loops that got continually smaller and smaller. And we did this through a series of 8 focus groups with 42 different community members in 4 target communities. And these, we targeted specifically language speakers of the 2 most widely spoken Mayan languages, Quiche and Kachikal. And these are also the communities that Wuku Kowak serves primarily. We conducted these focus groups and then followed up with 16 in-depth interviews with community health workers, nurses, and physicians to really understand what were the community's basic understanding around vaccines and what were the barriers to the uptake. There are logistical issues in terms of supply with getting vaccines out to the communities, but at the same time, there were a lot of myths and misinformation that were preventing people from actually wanting the vaccines themselves. And so this is really the area that our project aimed to target. And what came out of this was, first of all, we learned that there's not much information in Quiche and Kachikal, and Guatemala has its own history with a lot of complications around whether or not people are going to really take up messages that are in Spanish from the national level. And so what came out of these focus groups was a desperate need for trusted information in local languages, contextualized so that communities really felt like this information was for them, trying to build the trust, which is what Wuku Kowak really intends to do in terms of operating locally within communities. We also identified 4 common myths throughout these focus groups and interviews that were really preventing people from taking up the vaccine. And the 4 myths that we really identified and wanted to address in our social media videos were that people were believing that the vaccines might cause death or illness. They may be related to infertility in both sexes. There were a lot of religious arguments against the use of vaccines and uncertainty around whether or not these vaccines were actually acceptable from that perspective. And then also myths around the vaccines maybe implanting tracking of microchips. These are actually myths that were not just exclusive to Guatemala. I'm sure others have heard of these, but we really aimed to try to understand how could we address these specifically for the local communities. So I'll move to the next slide. So we wanted to create our vaccine education video series in the 3 target languages. And so I just wanted to share a screenshot of what these looked like. Essentially, we're creating the same content, but trying to bring in that contextualization around the local voiceover, the use of local voice artists. So here is a bit of what the image would look like. The thumbnail people would be scrolling through their Facebook feeds or their Instagram feeds, which we also determined was going to be the best social media platform for reaching communities in Guatemala. So moving to the next slide. I'd like to show just a couple of examples of the content in the 2 different languages, just to kind of get so that you can get a sense of what it looks and feels like in the 2 different languages with the identical images. Maybe you can play the first one. Let's see, do we have sound, Sime? Are others hearing sound? You might need to go off mute, Sime.
Okay.
Kurnachini perochopa, honam likidiba. Wihanila ya samarchu kana ansiro chakur, nanachin qashona chakur, payaren kurchawe, chira chakur nachini perochopa, honam likidiba.
Khurkut wachinik. Wari at kabang nima choka ria bakril ka pashawik. Arek uwa khurkut wachinik chiria bakril ka dahin kutorib. Kahuna matak uwa afruk levakun. Chirkuya uchoka lekabak.
Thank you, Sime. So all of these videos are available at the links that Kat shared, but just a few comments on the videos themselves. I think you may have seen there's the 2 side by side of the agricultural worker and the person lifting weights. So we really got feedback throughout the focus groups and continuing to get feedback through our our colleagues at Wuku Kowak around trying to be representative to the different contexts in Guatemala. And so one of the things that we wanted to highlight is that we were bringing in different visual images. Some of this content was already created, in fact, for an audience in New Zealand. And so one thing we wanted to really highlight is that by using animated visuals and by bringing in a cost-effective way, modifications visually, we were able to try to get to that resonance so that the target audience members would really be able to identify and connect with the communication itself. The other thing to highlight here is that we also were able to pretty easily change the visualizations around the local dress. And so trying to incorporate more of that, the clothing that would be recognized by the local audience. All right, so we can move on to the next slide. We then rolled out the social media campaign across the entire country and targeted ads by commonly spoken languages. So we had Quiche promoted in 7 different departments, Kachikal in 15 departments, and in the 2 target communities where Wuku Kowak works most closely, we actually promoted all 3 videos because of the prevalence of languages spoken in those communities. All right, moving to the next slide. So throughout this, we wanted to understand our reach, but we also wanted to understand effectiveness. And so one of the things that we do throughout our work is try to build in an evaluation plan at the very beginning where we try to understand the needs of the target audience and then identify key outcomes that we hope to affect throughout the implementation of distributing the content and getting it out into the local communities. So just to start, our social media campaign nationwide reached over 9 million views across 3 million unique viewers throughout the 4-week window in which we actually promoted the content. And so videos would show up in Facebook, Instagram feeds, and they would be, then available to be viewed. We actually placed the ads in strategically so that we could test the effectiveness of Spanish versus the Mayan languages, because we want to understand whether or not having information available in the local language is actually going to be more effective. And what we found was that the Quiche videos did appear to improve the perceived safety of vaccines in the Quiche speaking group. Spanish videos also may have improved the social acceptability of the vaccine among Spanish speakers. To also understand the impact on vaccine uptake, we conducted pre and post surveys in the 4 rural communities that we really targeted working with Wuku Kowak, and found that those who had reported seeing the videos on social media actually had 1.78 times the odds of getting their first COVID vaccine by the time we had conducted the post survey. So that is a bit of our process, and I will now, I believe, turn it over to Nopiwe to lead us into discussion.
Thank you so much, Jamie. Thank you, Sime. Friends, feel free to pop into the chat, introduce yourselves if you haven't, and also drop a question or a comment. We'll be taking those now. Thank you so much for the presentations. So go ahead, I'll give you a couple of seconds to type in quickly questions. But while we think about it, I'm going to invite, you don't have to direct your question to anyone, but definitely on our panel, we'll have Sime, we'll have Vicky, and we'll have Jamie. The rest of our team is here. We'll chip in wherever needed, but please feel free to ask the questions either about the case study or about the work that we do. I'm just going to get us started while you are typing in your questions. If you cannot type in the chat, feel free to raise your hand. So use your reaction button and just raise your hand, and we'll take note of your hand and hand over to you. But just to get us started, I want our panel to just comment on what changes need to be made currently to digital education to effectively improve health equity. Let's just get comments on what needs to change in order for us to effectively improve health equity.
I'll get the ball rolling if I can start on health equity. I think one of the things that we think about a lot is both who are the target audience and what access do they have with regard to devices, data, internet. And really trying to be mindful of who won't have access to those things. I think some of our content is very sort of high tech appearing, but in a moment I'll turn over to Sime to talk about how we manage some of those things. But really thinking about how do we make sure whatever topics and content areas we are creating curricula about, we also think about who else could we reach with different types of curriculum. And that has been the purpose of using methods like IVR. So IVR is a collaboration with Viyama, who some of those on the call may know, but it's all only audio based. And so anybody with a flip phone, a standard cell phone, can call in and get to that content at any time that's on demand. So I think being mindful of access is always most important, but also being really thoughtful about all the things that go into access that's not just device-based, but also time-based, data-based, and anything that takes sort of a resource to access the content we want to be mindful of. Sime, do you want to talk a little bit about sort of how the material becomes downloadable and data usage and those types of things?
Sure. So we have our content available in a few different ways. We have all of the content on our mobile app where you can download it to your device and view it offline. We also make assets available on our website, and all of this is open access with Creative Commons licensing to share alike. You can read more about the specifics on usage on our website. Thanks, Kat. But we do try to design these assets in a way that is conscientious of the overall file size. So thinking about how can we give the information in a concise way, thinking about the visuals and how they impact the file size, and making sure that that isn't going to stand in the way of people accessing the information. This is always a challenge, and I think we're always looking for ways to push this even further to make the content more accessible. So I think file size, visuals, and also just thinking about the language we're using and making sure that it's understandable to people with various education levels and language abilities.
One more thing to add, I think we try to be mindful of curricula that's accessible to different places and can be used in different places, but also when developing the actual scripts, one size does not necessarily fit all. So for instance, myths and misinformation may be different in different places. And so we really try to understand from our partner organization, what are the myths in that area that people may be wrestling with and hearing about, and specifically address those. So I think part of equity is being mindful of the differences in which the sort of in the place where this content will be heard and reviewed.
Thank you so much, Vicky and Sime. Friends, I will keep encouraging you to add your questions to the chat. I don't see a question yet, and I don't see a hand, but I will go ahead and ask the next question to our panel, just to comment on this. I mean, how do we make sure that we get more eyes on our health materials, and which methods have you found most successful, and what did you find more challenging? Vicky touched on contextualization earlier, but how do you just speak more about how you can get more reach and more eyes on content?
And I can just jump in here with a little bit more context on why we're really interested in this question. We often in online education, there is this misnomer that build it and they will come. And I think that there's, in reaction to the pandemic, there was a lot of online content that was created to address this really pressing health need. And some of the things that we created even early on in the pandemic, such as a collaboration with the emergency medicine department at Stanford to really address key training for health workers to treat COVID, got a lot of access. There were a lot of people who logged into Coursera and to edX and to our app to access that content globally. One of the things we wanted to understand was, is that content that we are creating that's really open source available out there, is it really reaching everywhere? And this goes to the equity question around, are we creating content that can reach the hardest to reach populations and the populations of most need? And not surprisingly, I think nobody would be surprised to see that in the lower income countries, in these kind of more rural areas, the access is still very difficult. And there are a lot of barriers to reaching access. And we actually started partnering with colleagues at the Open WHO, who also really wrestle with this question of how do they get their content out across many different areas of need, similar to the content that we try to create to address reach in these lower income countries. And one of the things that we learned is that just as the Chic training, the advocacy training in Uganda, in terms of the digital content being available to everyone, that just wasn't going to be the case. And so can we create content that also has support, such as job aids for health workers to go out into the community to take things in printed materials and bring that digital education to everyone through offline means? So these are one of the questions that we're trying to wrestle with around what kinds of supports that we can provide to complement digital health education. So, we really welcome questions and thoughts or suggestions around how we can improve this aspect of our work.
Go ahead, Vicky.
Just to add to that, I think part and parcel is making sure that we have a strong partnership with the trusted distributor. So in some cases, the trusted distributor may be a Ministry of Health, and in other cases, the most trusted distributor is the community health worker that knows the family, that the family trusts and is asking questions to as it is. And so being mindful of who will be communicating the information or telling somebody that this is a good course to listen to or a good video to watch is really important in making sure that it's believed and that it's meeting the right eyes.
Thank you. If anybody else has ideas really on how to get more reach, we've written in the chat. Also, feel free to give us ideas on how to do that. Talking about that, I just was thinking about collaborators as well. How do you get collaborators? But I also would like Sime to expand a little bit more on this interesting point she made in the beginning, showing us a production pipeline. And she said we try to talk to collaborators often and early on in the stage before developing things. Maybe just tell us more about that and tell us how you find collaborators who are relevant.
Sure. So yeah, our process really, we talk to them about who they're working with and who the audience is that we're trying to reach, and we walk through a series of questions, really trying to understand who the audience is. So kind of when are they accessing information? What are the contexts for learning? How do they currently learn the information, or what are the barriers that are making it difficult for them to learn? We think about misconceptions and a specific maybe mindsets that might be preventing them from accepting information as well. And if there's a way for us to address those in the design of our content, we try to do that as much as possible. We think through a lot of these early questions about just who it is that we're designing for, and whenever we can, if they can help us to connect with actual learners who would be taking the content and giving us more feedback. I wonder if Arthi, you might want to share a little bit more about how we form those relationships with partnering organizations and how we identify those good partners.
Yeah, I think a little bit of it is reactive, some is proactive, but essentially, I think we learned very early on that our work can only have the impact if we have really strong collaborators. Those are the ones that are on the ground, that understand the needs better than we ever could. And we want to focus our skill set uniquely on the education and the impact evaluation, which we feel like we can do more uniquely. So sometimes partners will come to us, asking questions. They've seen our content in some venue, and that they have a particular need. Sometimes it's using existing content, and sometimes it's brand new. We've started to join some of these more organizing type groups, like I think was referenced earlier in the presentation, the Community Health Impact Coalition, which is a wonderful group of lots of different organizations, all involved in the same space, kind of hearing about the same needs. And it allows us to kind of present what we have and ask for partners that might be interested in working with us. So that's more of that proactive solicitation of, here's what we think we can do, and do others have the need. We're getting more involved in venues like this, where we're trying to kind of just get the word out to share what we can do and see if there are opportunities for partnership. So it's kind of both. People come to us, and we, through these associations and kind of venues of people that really care about these issues, we're trying to find aligned organizations so we can have that impact in the distribution side and getting the content out to more people.
Thank you so much, Arthi. We have a question. We have 9 minutes on the clock. Linda is asking, can spiritual groups or leaders help to engage families to incorporate this type of lifelong and immediately relevant learning? So the role of spiritual groups or spiritual leaders in engaging families in these high need health education areas. I'm going to throw it back to the panel, but Jamie, I want you to take a first jab at this, as the Wikiwuku study was even more grounded in the community. What do you think about the role of spiritual leaders? Linda, please also feel free to chime in if you want more clarity, or if you want to clarify the question more.
Thanks, Nopiwe. I think that's a really great question, Linda. And I think that early on in the pandemic, one of the things that we did very early was reach out to NGO partners, specifically in South Africa, given our presence there, to really understand from NGO leaders, community-based health organizations, what do you need, and what is going to reach your communities. And one of the resounding things that came out was that there are a lot of different types of leaders, a lot of different groups within communities that are very trusted. And those include spiritual leaders, those include religious leaders, those include tribal leaders. There's a lot of work that I think that we need to do as we create digital health education to reach out to those trusted messengers in communities. And I definitely think that there's a place for that. And one of the things that we try to do with our content creation is to make it available to different groups to be able to use and to try to understand and even collaborate with one another. So one of the things that we also did early on in the pandemic is not only make our infographics and our videos available, but make them customizable so that they could be co-branded by organizations that were specifically working in communities, so that they could say, look, this is the message that we kind of vet and trust and can be used to reach, to communicate basic health information, but it's coming from this kind of collaboration. So it isn't just health information that's coming from some university that's not familiar necessarily to a community, but really coming from trusted individuals within communities. And I definitely think that, spiritual, religious groups that are engaged in this type of community health work, there's definitely a place for that.
Thank you so much for that great answer, Jamie. Anybody else want to comment on this? Thank you, Linda. Anybody wanna give a comment?
I think just reiterating that the partnership with whomever is the most trusted voices, both in delivering information, but also in early on gathering understanding of the concerns or the messages that people have been talking about in the community, is really part and parcel to making sure that whatever we put out is both relevant and I think, going to have that impact that we're hoping for, because otherwise it will just sort of be lost. So I think those spiritual leaders, for instance, Linda, to your question, are most important for communicating to us the concerns so that we can communicate back messages that address those concerns that may be barriers to better health long term.
Yeah, and I think, I'll just quickly add to that. I think a lot has become politicized around vaccine education. And I think that one of the things that we have learned throughout this process is to approach all of this with empathy. And so in terms of communicating to someone who has a valid concern about, is the vaccine safe? Does it go against my religious beliefs? I think that we really have taken the stance that these are all valid questions that need to be addressed, and it isn't just a matter of kind of throwing information at someone and trying to suggest that they should just be accepting it, but really understanding, where is this question coming from? How can we really get to the root of what's the concern? Can we present the information in a way that, approaches it with empathy and understanding around where a person is at in terms of how they believe certain things about basic health information?
Thank you so much, Jamie. I think all of this is so important. Not because we create digital information, but that the essence of Digital Medic really tries to reach out to communities and people who really need the information. So contextualization and the ideas of trust become so important, that we need to know exactly who is trusted. If COVID taught us anything, it is that information, doesn't matter how beautiful, coming from ivory towers, from the most knowledgeable people in the world, it still needs to come from sources that are trusted. Otherwise, it'll be useless. Friends, I think we are about at time. We are 4 minutes through. And thank you so much for joining us. Go to the chat, click on every link that Catherine has shared. That will lead you to our website. It'll lead you also to our downloadable app, which is available on iOS and on Android. It'll lead you to some of our material, and feel free to check us out on YouTube. Go to our webpage and scroll around. You might just find something that's useful, or that you can share with an organization that you know, and possibly a new collaborator of ours. So thank you so much. If nobody else has a question, I would like for us to close, but I'm seeing that in the chat, we do not have any more questions. So yes, feel free to also, if you have a question later on tonight, the next day, go onto our website and reach out to us, Digital Medic, and we'll be happy to talk to you there as well. So thank you so much. Thank you to our panel. Thank you, Vicky. Thank you, Jamie. Thank you, Sime. The presentation was good. Thank you, friends.